Yeah, thank you very much. I will talk in a structured way about a range of studies that we've conducted over the years at the Africa Center for Health and Population Studies in rural KwaZulu-Natal, which is a population-based surveillance site in South Africa, in the poorest district in South Africa, where the Human Development Index is lower than that of neighboring Swaziland. We've just heard from Velepi about the Swazi Treatment as Prevention MaxArt study, which is excellent, and we are very close to Swaziland here in this setting, and I will present a range of impact evaluation results, and I will structure this presentation by 4 criteria, which are all important when thinking about what outcomes you want to capture and how we want to capture these outcomes through different data structures and different study designs. The first one is, of course, the scope of outcomes that we're interested in. Are we interested only in the preventive effect of ART, HIV incidence impacts? Of course, also survival is a health outcome that is the primary motivation for ART, but employment, economic spillover effects, educational attainment in children due to treatment as prevention and HIV treatment are potentially alternative outcomes that are very important to look at, and we do so, and we also do so in an ANIS-funded treatment as prevention trial that is currently ongoing at the Africa Center. Then second question is, what is the target population that we are interested in? Are we only interested in effects in those on ART, or also their household members who are not receiving directly ART but benefiting potentially from a household member's ART receipt, or also non-infected community members that are not directly related through household and social ties to the HIV-infected person receiving ART. The degree of realism is, of course, important when we look at outcomes and data structure and study designs. In general, I think we want a high degree of realism, but of course, we also want efficacy proof. So in treatment as prevention trials, we need best possible rather than real-life conditions, I would argue. And strength of causal inference, we of course want the strongest causal impact evaluation design possible, and I think here we have often not the opportunity to do the most rigorous study designs where we can control through our approach for observed and unobserved potential confounding factors as we can in experimental studies, but we have observational data and can control for observed factors, and sometimes, and I will make a case that that is important, also in quasi-experimental studies relying on observational data. And that's related to the structure of my presentation. I will structure it in non-experimental findings, quasi-experimental and experimental ones, which is more an update about what we are doing currently and are working on in the ANIS-funded task trial at the Africa Center. This is a map of the population. We see here the demographic surveillance area. That's the gray shaded area, HIV surveillance. That's a population of about 90,000 individuals in about 11,000 households who we visit twice per year in a household surveillance and once per year in an individual behavioral and HIV testing surveillance. The red little crosses are primary care clinics. In all of these primary care clinics, now ART is available over our observation horizon, which starts here in 2000. ART is coming online in these clinics consecutively, starting with one primary care clinic located here where Kwamsane is written, then branching out to another primary care clinic. This was never a centralized ART program. It was always a devolved ART program where only primary care clinics administered and provided ART. It's also a nurse-led program, not a doctor-led program, because there are hardly any doctors in this district in KwaZulu-Natal. The overall economic situation here is poor. 2/3 of the population do not have employment. The majority of the households depend on South African grant income for their livelihoods. And the second area, that's this colorful area with a yellow and red and blue shading, that's where the treatment as prevention trial is ongoing, and it's structured in 3 phases, which are indicated here in these color schemes, yellow, red, and blue. ERT scale-up in this population has been very vigorous, so by now 7% of the total adult population are receiving ART. That's the adult population above 15 years of age, and maybe 1 in 6 adults is actively enrolled in the ART program, either in pre-ART or in ART. And a non-experimental finding that is an extension of the paper in Science that we published last year, where we showed essentially that there's a very strong dose-response relationship between local community ART coverage and the individuals who we enroll as an individual, as an HIV negative person, and follow up that person in a cohort precisely in the same manner as a task trial would over time here over by now almost 10 years, and observe that individuals' ART acquisition risk in relation to the ART coverage in the local surrounding small individually determined community, controlling for HIV prevalence, of course, in that community, but also for a range of social and behavioral potential confounders. It's essentially the same data structure and the same design that a task trial has, with the one exception, which is of course critical, that here the ART coverage in the community is not randomly allocated. It is allocated by some process, by policy and nature, which of course theoretically could be related also to the HIV acquisition risk in a way that we cannot perfectly control for using observational data. And as an extension here to the science findings, we have since the previous paper seen, of course, increasing ART coverage. So we are now seeing the acquisition hazard in communities of HIV negatives at baseline in communities that have 40 to 50% and above 50% ART coverage of all HIV positives in this community. And we see that there's a leveling off of the effect at about 40% hazard reduction for HIV acquisition. And here is a related finding where we did a similar analysis looking at the household protective effects of ART coverage, and we find that ART coverage in the opposite sex in your household protects you in a matched age stratum as an HIV negative person in this household significantly and relevantly from future HIV acquisition. For instance, a 50 percentage point increase controlling for HIV prevalence in the household and other confounding factors, a 50 percentage point increase going from 0 to 50% household opposite sex coverage for ART reduces the hazard here by 26%, a 60 percentage point increase by 30%. Again, enrolling negatives at baseline. The second major health outcome, of course, or the primary one, of course, regarding ART is survival. And here we have, I think, for the first time shown the rapid increase in life expectancy following ART scale up in a community where HIV prevalence now is 30%, and we see this dramatic increase. The vertical dotted line here is when ART scale-up is starting, and with ART scale-up in time moves life expectancy here at this dramatic pace of an increase of 1 year life expectancy gain per calendar years. That's one of the fastest life expectancy gains observed in the history of public health. But of course, it's hard to infer causality, and one approach that gives us a little bit more belief in the causality here of this dramatic life expectancy increase is when we look at the HIV cause deleted life expectancy. Here I've divided this picture by men and women because women benefit more than men in this population. But we also see, and that's the red line or the red bars, that HIV cause deleted life expectancy, that is the life expectancy of those who are not dying of HIV related causes, remains perfectly beautifully stable over the observation time here over this decade from 2011 to 2012. And in the presence of major underlying secular confounding factors such as human development increasing, better sanitation, better access to safe water, nutrition, less hunger, better economic development, we would see these lines moving as well, and we don't see that. They remain stable here at 75 years for women and about 65 years for men, which also tells us that there's a long way to go for the ART scale-up in this community until we've reached this level of life expectancy, which is probably the life expectancy in the absence of mortality effects of the HIV epidemic in this community. And here, from an impact evaluation where we looked at the household effects of ART, we compare, and again that's observational data if you will, even though we control here for household fixed effects, we see in the blue line the movement relative to the point of ART initiation in households where a person gains access to ART. And we see that household wealth, captured here with an assets index, or rather an asset count, remains completely stable. And of course this could be because HIV doesn't have an effect on household wealth, and ART thus cannot have a compensatory effect. So in order to gain a bit more insight what is going on here, we compare another type of household in this observational study where someone who needs ART is not receiving ART and thus dies of HIV-related causes. And that's the red line, where we see a decline in household wealth going towards the HIV-related death, and then a continued decline afterwards, which looks like it will be permanent. So there's evidence here from this observational study that indeed ART can prevent these detrimental household wealth effects of HIV infection. And then, of course, sometimes we have these opportunities where we can, in observational studies, mimic something like an RCT. And there are what I would call maybe the strong quasi-experimental designs where we can, if we are lucky, perfectly control for uncontrolled confounding, unobserved confounding, and the weak quasi-experimental studies where we can perfectly control for unobserved confounding, but only for time invariant factors, not for time variant factors. And one example that we think is very much underutilized and very important for HIV, potentially, for HIV impact evaluation, is regression discontinuity. This is from a forthcoming study where we refute in PubMed the universe of quasi-experimental studies, and here for regression discontinuity we find precisely 18 studies ever using the study design, which is a scandal in my opinion, because it has such attractive features. And most of these papers are journals of health economics rather than public health journals. So we have here applied for the first time regression discontinuity approach to estimating the programmatic impact of ART on mortality. And we can do that when we have a variable that is continued, a so-called forcing variable that is dichotomized in a decision-making rule. Here, of course, for treatment assignment, CD4 count, below 500 you should get it, or below 200 here in the early days in South Africa you should be on ART, above 200 you should not be. This doesn't have to be a perfect rule, and what we see here is in bins of CD4 count plus minus 10, these are the little blue dots, that above 200 you are 6 months after appearing at an ART program 25% likely, if you're just above 200, to be actually initiated on ART. So some people who are above 200 of course are initiated, and that's a declining trend with increasing CD4 count. And equally, if you're just below 200 you're 75% likely to be on ART, and that's a slightly increasing trend, also expectedly with decreasing CD4 count. And it is this discontinuity at that threshold of 200 that gives us the ability to see now the mortality impact of ART by looking at outcomes in those just below and just above that threshold. And in comparing those, and that's essentially those on either side and just below, just above the red line, which is our CD4 count 200 cutoff, we see that there is a mortality differential here, a differential in the hazard that's about 30%. So this program, in those ever accessing the program, has a 30% mortality reduction, and that's very strong causally, because in that small neighborhood people are as good as randomly assigned. And that's because there's random variation in nature. There's measurement error, whether you fall just below or just 200 in the same blood sample, depends on whether you test once or twice or thrice. It depends on whether you've run to the clinic, whether it's a hot day and you've sweat or consumed a caffeine-containing drink. So all these random noise factors influence the assignment, of course, only in a small neighborhood just above and just below. So here we have mimicked an RCT at the threshold, which is important, I think. And then in a weak quasi-experimental design, we looked here in an individual level fixed effect analysis at the employment in ART patients long before they become ART patients, long before they suffer the employment-reducing effects of HIV infection and then potentially, hopefully, the compensatory effects of HIV treatment. And we see here for the first time that in these individual level fixed effects analysis, people not only gain employment probability, but they regain or perfectly recover their employment probability that they had many years, 5-8 years before they went on to ART. And here in a difference in difference analysis, again, I would classify that as a weak quasi-experimental design because we cannot control for time varying confounding factors, but we do control perfectly for time invariant confounding factors. We have evidence for a net economic stimulus effect of ART in this community, which is of course plausible as we invest so much, millions of dollars here in an ART program which goes hand in hand with employment, with patients needing to access food while waiting for ART, that there is an economic stimulus that we see here with increasing employment probability amongst both HIV negatives and positives in this community. And finally, of course, sometimes we have the money and the opportunity to do major experimental studies, and the Africa Center was the first center that with ENIS funding in 2012 started a treatment as prevention trial, which is here in this second area, different from the surveillance area, but neighboring, where we've randomly assigned 22 clusters, or will eventually have randomly assigned 22 clusters to test experimentally the treatment as prevention hypothesis, which of course you all know. And here is the very simple, straightforward study design. We assign communities to receiving home-based testing, and in one community you receive ART under the current ART standard in South Africa, and in the other community under a treatment as prevention paradigm. And in addition here, which I think is important, and I'm co-leading with Silly Boyer in this trial, the economic and health systems evaluation, we look at patient outcomes that are not health outcomes, and they are important because we can here establish the causal effect, of course, on household wealth, on employment, on healthcare expenditures of treatment as prevention, and factors such as acceptance, perception, experience of ART and HIV testing, ART knowledge, and sexual behavior. So in conclusion, I think in general we all agree that a wider scope of outcomes is better, broader population outcomes are better, a higher degree of realism and stronger causal inferences are always better. Of course, when we need efficacy proof, degree of realism is not what we want. We want a best possible conditions result, and also these outcome criteria, of course, trade off against each other, and often gaining better criteria is costly. So I think there is much to be gained by employing quasi-experimental studies, more commonly in these types of impact evaluation studies of HIV treatment under real-life conditions, and HIV treatment as prevention under real-life conditions when it is rolled out, for instance, as will be the case, it seems, at some point soon in Swaziland. And I thank the Africa Center colleagues and our funders. Thanks.